Welcome to Brainstorms, Functional Neuro Rehab for SLPs, presented by SpeechTherapyPD.com. This podcast is designed for the adult medical speech-language pathologist. Most of our audience members work in settings such as acute care hospitals, private practice, outpatient hospital clinics, and inpatient rehabilitation hospitals. Each episode has an accompanying audio course on SpeechTherapyPD.com and is available for 0.1 ASHA CEUs. The content of this course is based on the research and experience of the presenters. The listener is responsible for researching to determine if the information and skills taught are appropriate for their clients, students, or patients. SpeechTherapyPD.com does not necessarily endorse, recommend, or favor the information shared, nor any of the claims, opinions, statements, offers, or services made by the presenter.
Hello and welcome everyone. My name is Renee Garrett and I'm your Speech Therapy PD podcast host for Brainstorms, Functional Neuro Rehab for SLPs. Before we get started, we have a few items to alert you to. Each episode is 60 minutes and will be offered for 0.1 ASHA CEU. Here are the financial and non-financial disclosures. Rachel Archambault is employed by Broward County Public Schools, and she receives compensation from Speech Therapy PD for this podcast appearance. She has no relevant non-financial relationships to disclose. My financial disclosure is that I'm a paid employee of a private consulting firm in the Commonwealth of Virginia. I'm also an instructor, an adjunct faculty instructor for both James Madison University and Old Dominion University, and as the host of Brainstorms, Functional Neuro Rehab for SLPs, and other webinars, I do receive financial reimbursement from Speech Therapy PD. My non-financial disclosure is that I'm the secretary for the Communication Disorders Foundation of Virginia. Now, without further ado, we welcome our guest, Rachel Archambault, MA, CCC-SLP, who is an SLP program specialist for Broward County Public Schools. After a traumatic event happened at her workplace on, Valentine's Day, February 14th, 2018, she looked for ways to help work with students and herself after trauma. She found trauma-informed care and has been presenting nationally to SLPs and other providers on how trauma-informed care can be used in their setting. She runs the Instagram account at PTSD-SLP, which discusses trauma-informed care from a speech lens. Welcome, Rachel, and thank you so much for being here with us.
Thank you for having me. I'm excited to be here.
Of course. Yeah, I think, this is a tough topic sometimes to talk about, but a very necessary one. I had the really great fortune of presenting on trauma-informed care last year in 2023 at ASHA on trauma-informed care across the lifespan. And it was, I think, Erin Forward, who was
Yes.
my co-presenter. And it was funny, we were talking about that this year, how last year, I think there was like 2 or 3 of us that presented, and this year there was like 50 courses, which is pretty cool because we're, getting traction and understanding not only what trauma-informed care is, but how it's applicable to us.
Absolutely. And one thing to mention, we are so far behind as a field. I have friends that are, in big corporate jobs, accounting, and they've been trained on trauma-informed care for the last 15, 20 years. And it's now, I was on the topic committee for trauma-informed care, which became its own committee last year, which is super exciting. We're now getting speech pathologists to go into it, and we're behind, but we need to catch up. And I'm glad to see so many people talking about it.
Yeah, same. And what's funny, and I said this not too long ago, people that should be even more up to speed, in my opinion, on trauma-informed care because they're touching people constantly. Physical therapy, skin estheticians, massage therapists, chiropractors, plastic surgeons, just to name
Yoga.
Yes, no trauma-informed care training required in not only in their academic portion of their training, but not in their licensure, and no requirement for ongoing throughout their maintenance of their license. So that's super interesting to me.
I agree. I part-time work at a Pilates studio, and I now understanding trauma-informed care and presenting on it the last almost 7 years, which is wild that it's been that long. Everything that I do in a trauma-informed mindset, or I'm constantly thinking in trauma-informed care. So when I'm sitting at the Pilates studio and I'm watching the instructor just grab onto someone and make the adjustment, I go, whoa.
Yeah.
And I don't want to say to my boss, can I do a trauma-informed presentation for the Pilates instructors? Like, I should, because there's a risk at causing harm or freaking someone out. And we want to make sure that we're not causing the harm in whatever role that we're doing. So whatever way we can reduce that harm, especially in our field as speech pathologists, feeding therapy, anything that we are touching people, even with articulation, oral motor movements, anything that we're like touching people or getting into their personal space, we need to be trauma informed, especially.
Oh, yeah, for sure. Yeah, and I do manual therapy, and that was one of the things that I was really it's discussed in a kind of different manner, but that's basically what it boils down to, is making sure that the informed consent is there. It's a shared decision-making process. And because my background is primarily in brain injured patients and patients who've had strokes, I think my approach was a little bit different even in the beginning of my career. I didn't know that that's what it was called, but
Yep.
I've always sort of operated from that mindset because, you don't go into a patient's room who has had a traumatic brain injury and just get in there and start touching people, whether it was from, a cognitive standpoint or a swallowing disorder standpoint or both. So I think that's important because we're looking at establishing not only that trustworthiness, but that safety spot, right?
Absolutely.
Yeah.
I One of the things that I present on, I use TikTok videos a lot. One of the videos that I present on is I use Teepa Snow. And for
Yeah.
any of you who are listening, she's an occupational therapist and she talks about the Teepa Snow method, which really is just trauma informed care, as being trauma informed to someone. One of the examples in her videos, she acts out a patient with dementia who has something on her shirt, and a caregiver, whoever is working at the home that she's living in, says, take off your shirt and put on this new one. And the way that I'm describing this is, if we know that this is a person with dementia, she may not know who you are, whether you're a familiar nurse, familiar SLP, whether they're your child, or your parent, I guess. We don't know what they know of you. And our goal is always to provide safety as much as possible, choice. And in that specific situation, saying, take off your shirt, we're raising their dysregulation. Oh, stranger, I don't know this person. Why are they telling me to take off my shirt? I don't know where I am. All of these things that we have to consider. And it also, from a safety perspective, it's also my safety as the provider, because
Mhm.
if I say this to the wrong person, they're going to come swinging at me, right?
Mhm.
So
Yeah.
I want to make sure that I'm safe in my position, whether I'm working in acute care, whether I'm working in a school, private practice, someone's home. We need to be as safe as possible. And that includes making our clients feel as safe as possible.
Yeah, no, I agree because the clinician safety has been, for a while it was talked about, and now, during the pandemic, and I think we've swept that back under the rug. But
Yeah.
having a background and working in inpatient rehab and acute care for the majority of my career, clinician safety is a big thing. Safety for nursing staff was also a big thing. I worked in a level 2 trauma center with a crazy ER where we saw anything from gunshot wounds to motor vehicle crashes, plane crashes, all kinds of stuff. So yeah, keeping us safe is paramount and keeping the patient safe. But then, and I've talked about this a lot on the podcast because I did work a lot with patients with dementia and acute care, especially. You go in to chat with the nurse and you get the handoff of, oh, good luck with that one. They're wild, or good luck with that one. They're not saying a word. And you go in and no one's actually talked to them. They haven't talked the patient through what's about to happen because they assume that if this disorder is present, then I don't need to communicate with them because they're not going to understand what I'm saying anyway. But that's really a basic human right, is to talk to the patient, tell them what you're doing, introduce yourself, all the things, right? That's just basic human courtesy. And so for a lot of people, I don't understand why they've they've lost that, or maybe they're just in a hurry. Any
Yes,
thoughts on that?
I have so many thoughts about that. And I think part of it could be that they're in a hurry. And what is that hurry is productivity in a lot of
Yeah.
these medical settings, right? So
Yeah.
if your hospital system is making you do 95%, 90%, 85% productivity, your ability to sit with a client and have that transparency part. So I'm sure we'll talk about the 6 pillars of trauma informed care.
Yes.
Transparency is always one of my biggest ones, especially in the hospital system. And I always talk about in my presentations, in acute care, they are coming to us because of a traumatic event. They are not there for
Okay.
funsies. They are there because something has happened that brought them to us. That could be a range of things. It could be a range of severity, but we have to be mindful that they may not have the medical background that we do, the educational level. I think all those things are somewhat considered, but also when we become so pathology like and we just start saying, oh, it's a stroke, he doesn't know what I'm saying, therefore I don't need to explain anything to him. That's part productivity, that it's forcing us to move quickly. That's unfortunate. Another thing that I talk about is trauma informed care needs to be at all systems above us. I cannot be 100% trauma informed as an SLP working in acute care if the systems above me, my admin at the hospital, the corporate level, everything above us, if they were able to reduce the productivity level by 5%, 10%, that is leaning more towards trauma informed care because it's saying we are prioritizing the patient. We're prioritizing that relationship building. And if they are keeping that, they're saying the bottom line is the money. And that's all we're really caring about. Everyone else is able to do it at 90%. Why can't you? So I have heard of several medical settings around the country where they do reduce the productivity. And that makes me so happy. Even if it's 5%, it's a step in the right direction saying, I'm listening to you. I hear you, patients and employees. This is something that we can do to show that we are going in that direction, and let's see what the patient outcomes. Maybe we'd have better patient outcomes, which that is what the research is showing, better patient outcomes when you reduce that productivity. So all of these factors together we can help advocate for, but again, I think if we're in a hurry and we're forced to be in a hurry, we can't be as trauma informed as we would like to be.
Yeah, no, I came from a health system that was 100% productivity.
Ah.
Yeah. Yeah, and I that was where I worked during the pandemic. So it was incredibly difficult, would be an understatement, because when coming from working with brain injured patients for so long prior to taking on the acute care role, it was a different mindset because I was in inpatient rehab before. So we were fortunate. My big director of rehab was a SLP, so she got it. She looked at our productivity from we needed to be at team conference with the team. With the physician was there, the pharmacist was there, the dietitian was there, all of our teammates were there. She got it. We needed to be there for that. We needed to be able to meet with families and provide education and work with the care team to try to figure out next steps on what discharge looked like for that patient and what the next level of rehab looked like. We needed to be able to do stroke education and TBI education with the neuropsychologist as well. So it was a much different. I came from that, and when I went to acute care, it's like you don't get to do any of that. You're the mule. That's basically what it was. You're the mule. You do all the work. Good luck. Meet productivity or else. And
Yeah.
the longer I was there, the more I'm gonna be honest, threatening. The environment was threatening at the end. It was not trauma informed by any shape. And, I came into an outpatient setting to start a program where they had a certain expectation for physical therapy and OT, which operates differently than us. They weren't doing a lot of neuro stuff. So when I came in and I'm doing all the neuro things, and I have head and neck cancer patients and trach patients and voice patients and all the things, it was very difficult to navigate that. Like you said, from the top down, those systems were not in place.
No.
It made my job incredibly difficult.
And even, I mean, you mentioned being there during COVID, which was highly traumatic for, I mean, the country, but healthcare workers in general, that it was so fast paced, the burnout, we have people who left the field, whatever
Mhm.
setting they're in. They're like, I'm going to go to dermatology and do Botox all day, like that's
Well, I left acute and went to outpatient, so
right. So there's many factors of trauma informed care being at all levels that the admin has to look at it towards how can I be trauma informed to my employees, because then the employees pass it down to the people that they are seeing. If
mhm,
workers are in burnout, if workers are so morally, not morally, what moral injury is what I'm trying to say. Moral injury is another word for like compassion fatigue. It
mhm.
affects healthcare workers a lot, but all of these pressures that the healthcare system continues to have and had during the first few years of the pandemic, this contributed to not trauma informed workplaces, and we saw people leave because of what they experienced. So in I hate using the term post pandemic because we are still technically in one. We are still having the effects of it. Um, I think what is happening is a lot of these agencies are looking at the needs of their employees, or hopefully looking at the needs of their employees to help retain. And what employees are begging for is trauma informed care. They want to be trained on it. They want their bosses to be trained in trauma informed care, and the organization itself to be trained in trauma informed care. And people are able to look for companies that have that in their mission statement, that we are a trauma informed place of work. And I think that's important to people now, which is, I'm so glad again that SLPs are finally getting this information. And it needs to be, even before we get into the profession, it needs to be in undergrad and grad school.
Yeah, yeah, that's a great point. And, you mentioned the guiding principles, so that comes from I'm probably gonna say it wrong, so Substance Abuse and Mental Health something agency.
Yes, I always forget those last two letters. It's
Me
SAMHSA
too.
is the abbreviation.
Yes, exactly. S
SAMHSA.
yeah, yeah. That sounds right. But they do, so there's 6 pillars, and we talked about safety, we talked about trustworthiness, but part of trustworthiness is also transparency because, being upfront again, thinking about patient care, going in or for school-based folks, you're still gonna go in and introduce yourself. You're gonna say why you're there, whether it's a student, whether it's the student and parent, or just the parent, depending on the meeting. You're gonna go in and you're gonna do those things because that is basic human decency, and we hope that everyone is doing that, but I know people that I worked with who did not, and we talked a little bit about voice and choice, that empowerment piece, but collaboration, when we're looking at not only collaboration amongst peers, because that's part of it too. You mentioned that piece from administration and those other layers of management, but also collaboration with caregivers who may or may not be family. Sometimes caregivers aren't family. They're people who
Yeah,
are legal guardians, or they're people who are neighbors or other people that are present in these folks' lives, whether again across the lifespan, right? Kids, teens, adults, geriatrics, it doesn't matter. It's still that collaborative piece is super important.
absolutely. So taking it back, trauma informed care, one thing that we always hear is the 3 to 4 R's of trauma informed care. It's realizing the prevalence of trauma, recognizing how trauma affects all individuals involved with the program, organization, system, including the workforce, which you and I talked about a bit just with the productivity standards, responding by putting this knowledge into practice. And then the fourth one would be resisting re-traumatization. So
Mm-hmm.
SLPs, I think, understand the depth of that fourth one, resisting re-traumatization, but don't necessarily know how. And it can be done through asking yourself questions about the 6 pillars of trauma informed care. So we've talked about safety, choice, collaboration. The 6 pillars of trauma informed care are safety, choice, collaboration and mutuality, trust and transparency, empowerment, and cultural, historical, and gender issues. So I always reflect within a session, after the entire day, throughout my career. I will continue to ask myself, how can I provide safety to this client? How can I provide safety to this family? Is my definition of safety different from their definition of safety? And as someone who's experienced a traumatic event, different people have different tolerance levels of safety or ideas of what safety is. So it's not for someone to say, I'm a safe person, you can trust me, or you're safe here. If their bodies and their brains or your relationship isn't showing that you're safe, then it doesn't matter that you're telling them you're safe because they're not feeling it. So we really have to meet them where they're at. Choice, collaboration, mutuality, trust, and transparency. Again, we talked about transparency. That's a really crucial aspect that I think a lot of people are forgetting, especially in the acute care part of, oh, they don't know what this means, or I don't need to go into like the surgery aspect of it or what the consequences are. They just kind of leave that out. Of someone along the way will have that transparency. Let it be the surgeon, let it be the doctor, whoever it is. And cultural, historical, and gender issues. That's a big one also, that in a field of SLPs, we are 90% women, 97% white, I think are the latest statistics. So we possibly are causing harm with the cultural, historical, and gender issues just because of who makes up this field. And that's a very difficult thing to say. One question that I always offer to people, and it's not, I don't ask anyone in presentations this, I ask people to reflect on it. And the question is hard. The question is, have I caused harm in your career ever? And I think a lot of people, no one goes into this field because they want to cause harm. They go into this field because they want to help. But the reality is, along the way, you possibly have created harm in some way. And that's okay to say to yourself, because I would rather you say, yes, I have created harm at some point. How can I make sure that I don't do that in the future, rather than say, no, I've never caused harm and I never will, because you are absolutely causing harm and you're missing along the way. You're missing the identification piece. Where can you improve upon? So this little activity of reflection with a specific client, maybe you're like, how can I be more trauma informed for this client? Go through all 6 pillars and say, where can I add choice? Where can I collaborate more, and collaborate with who? And I also talk about it with collaboration with the patient itself. One thing that I saw I worked at a skilled nursing, and I remember rehab taking this like 80-year-old woman and having these sheets of how to bake a cake or how to cook or something like that. Meanwhile, if you would have asked her or her family, she never cooked a day in her life. It was just something that, oh, here's this age group and she's a woman, she probably wants to bake. There was no collaboration there. So she's looking at everyone like, I don't want to bake anything, but she's not able to communicate that. So she just sat there and was going through the motions of it. That was a total waste of a session with her. We need to be looking at functional skills, whether that is her priority of being able to say her grandchild's name again.
Yeah.
That's the functional part that we are also, by asking that collaboration piece, adding on safety, adding on choice, adding on empowering, right? So the pillars don't stand alone. I like to think of them as a waterfall. They all fall into each other. If you're meeting one, you're probably meeting another. So just continue to ask yourself, where am I providing this to this client along the way?
Yeah, and that's so funny that you say that, because I've shared the story quite a few times on the podcast and in other presentations I've done. But when I was a student, I had a clinical instructor when I was off campus, and I was at a really awful, I mean, this place was awful. It was just awful. And the SLP that was there was just not, yeah, that could be a whole entire podcast. But the point is, she was wheeling all of these patients who were long-term care residents into a cognitive session of group, which is not a thing. It's not even accurate to bill that way at that time. And she had a lady who was, I think she was about 94, if I remember right, but it was the same thing. They had all these worksheets and they're going around the table and they're asking these questions, and they asked her, it was problem solving, and they asked her the question of, what would happen if if you didn't change the oil in your car? And her response was, and this was a African American female almost 20 years ago, in a wheelchair, diabetic amputee who'd been in long-term care for about 10 years without a diagnosis of anything cognitive related, who seemed pretty sharp to me because she introduced herself and told me how old she was and where she came from as soon as she entered the room. They asked her this question and she said, well, I'm not exactly sure. I've never owned a car and I've never driven. And they marked her incorrect on her worksheet of sample questions that had nothing to do with her, what her needs were, what her life had looked like. And it just, as a student, even, it sat so ill with me that it still bothers me. It's been a long time ago and it still makes me angry to think that they did that, because it wasn't, there was nothing about that that made her trust anyone, want to collaborate with anyone. It wasn't empowering for her in any way, shape, or form, nor did it reflect her history, whether it was her gender or just her life experience. Her lived experience was very different from some of the other residents there, but it still should have been accounted for and taken into consideration. And
I think
that's a really simple, like a really simple example, because I think sometimes people get overloaded by trauma informed care that we assume it's got to be like a car accident or an accident or something like that, but it can be something really simple.
it can. And one thing that I like to say is trauma informed care to me is preventative.
Mm-hmm.
Trauma informed care is for when you don't know the traumas, the background history of someone that you're working with and wanting to prevent causing harm. After something happens, after you know specific details of their past, of their trauma, then it becomes trauma sensitive or trauma specific, which
Mm-hmm.
that's a whole other level of being able to carefully or even more carefully prevent harm,
Mm-hmm.
prevent you from causing harm. So one thing that I think about is language changes. Language changes are so easy to do. One of those language changes being violent language. So actually in one of my presentations, I think it might be 2 years ago now, there were these phrases that I kept hearing after what happened, a traumatic event with me, that I was like, these are icky words now. And we just don't say them. And I don't know why that is. And what I learned from this person whose daughter works at a domestic violence clinic is it's violent language. And
Mm-hmm.
anyone who works there or lives there has to eliminate them from their vocabulary, because the likelihood that the people who are there have experienced a traumatic event from domestic violence, whatever it is, and these violent phrases are stressful and triggering. Just by removing them, this is a trauma sensitive or trauma specific thing that we can do to make sure that we're not causing unnecessary harm or unnecessary stress. For me, I don't ever say violent language in general. Violent language being shoot me a text, shoot me an email. And after you listen to this, whoever's listening, you're going to go, oh my gosh, I did not realize how many violent phrases are in our culture. And it's staggering. It's a very strange thing to start recognizing of, ooh, that's a violent term. That's a violent term. But I've eliminated it completely from my vocabulary, because if I'm walking into a kindergarten classroom, I don't know who's experienced what. And it's not for me to say, oh, based on this age, they've not experienced anything, because that's wrong. It's the
Right.
same for me walking into a Veterans Affairs, because I want to remove that violent language, because I know what history they have, not specifically, but there are certain things that when you start working at a VA, they say, don't wear this color, don't wear these boots, don't do this, because they know what the triggers are of that specific population. That's trauma specific and trauma sensitive. So trauma informed is the precursor to that, but trauma informed is for when you don't know. And for those of you in acute care or this fast paced medical setting, you're not going to get that extensive medical background or trauma background. You're not. So we can only try with the trauma informed stuff, asking yourself the 6 pillars. Where can I provide more safety? Once you hear something, once you find out something about their past, then you can adjust it. And it's still trauma informed, but it's also kind of trauma specific.
Yeah, I know things like don't wear your badge on a lanyard around your neck, or wearing I don't even work in the setting anymore, and I still don't wear jewelry because a lot of my clients are intellectually disabled and have a lot of mental health diagnoses as well. So I'm not someone who's going to go in with a necklace on or other jewelry that could be used inadvertently, because that's how I was trained. But we were trained in nonviolent crisis intervention from a physical standpoint and a behavioral standpoint, but not necessarily in a communication standpoint. But there is a really good, and I'm sure you're familiar with it, the book Nonviolent Communication, A Language of Life,
Yes.
Rosenberg. That is a really, really great resource. And it was something that I was introduced to from a colleague that I wasn't looking for, but it's very helpful and definitely gives some insight into specifically what you were talking about. We did have a question. Someone said, are you or were you able to write goals that addressed patient education as a way to incorporate psychosocial needs? And I think we probably could both answer that. For me, working in healthcare, yes. We didn't necessarily write it as a goal, but it was part of the comprehensive treatment plan when it came to our team goal, not necessarily specifically in my speech evaluation or my cognitive or language evaluation, but it was typically in our team goal in inpatient rehab. We had goals about addressing patient education. But I think there's certainly ways that you could word that from a psychosocial standpoint that would probably also be really helpful.
And I also come from my full-time job now. I've worked in the school system for the last 9 years, and I'm working on these IEPs. One of the biggest things that I always attach to a speech or language goal is self-advocacy. That is one of the biggest ones. And we also need to have that self-advocacy component in the medical setting, because it's life or death in some of those situations. They need to be able to advocate for themselves, whether it's I need to use the bathroom, I need to eat, whatever it is, I don't feel well, something hurts. We need to have that self-advocacy component, which is so important in educational and medical setting.
Yeah, and it's interesting because that's the same thing. I met with a client today he's an adult with autism and verbal apraxia, and I met with him and his family today about looking at a supplemental AAC device. And that was one of the things that his mom brings up a lot is he can't advocate for himself. And so that's sort of what we're looking at is as he ages, his parents who are his supporters are also aging and they're his legal guardians. And so what happens to him when they're no longer around and he
Yeah.
can't always verbally communicate? And so that's another consideration is thinking about how we make that advocacy accessible to patients who may not have the independent voice.
Absolutely. Yeah, I agree with you there. I was also just thinking about trauma-informed care is just as much about preventing harm to others as it is acknowledging harm with ourselves or knowing what's going on in our bodies. And the medical setting is insanely stressful. And so is the educational setting, especially I'm in Florida. It's very stressful. No caseload caps. It's the Wild West over in the Southeast over here. But one thing that's very important with trauma-informed care is understanding your own emotional regulation, your dysregulation. So it's important to acknowledge that your clients, the clients' families, they will stress you out. And what do you do with that? So one of the reflection tools that I use, that the bottom one is am I causing harm? At the top, I always ask SLPs to ask themselves, do you know your stressors? And for me, my stressor, or one of them, is noise. And it doesn't have to be loud noises, sudden noises, just repetitive noises. I get so distracted by them. And then I have to acknowledge, what do I look like when I'm stressed out? Is that I get very tense, I'm short with people, I go silent. So if one of my students is asking me, hey, Miss A, are you okay? And I go, no, don't worry about it. I'm teaching these children to figure out body language and context clues. And they got it correct that something is wrong with me, but I just told them they're wrong. So when you look at in terms of like the pillars of trauma-informed care, I'm not showing that I'm safe. I'm not showing trustworthiness. I'm not being transparent. I don't need to say, well, my boyfriend broke up with me and blah, blah, blah. No, but I can say, I'm having a hard day today. Thank you for noticing. And
Yeah.
I could do that in the medical setting. Like, that's part of relationship building of, thank you for noticing I am a little off my game today. And that's so, so important. Are you able to identify when you're stressed? Some people can only do it way after the fact, that like, wow, I was a little tense earlier, and not in the moment. It's better to do it in the moment, but whenever you get around to it. And then, do you have any coping strategies? That's the biggest one that I feel SLPs don't have coping strategies. If they get stressed early in the morning, they are stuck in traffic on their way to work, they are stressed the rest of the day.
Yeah.
And that, I'm not saying that by you being stressed, you're directly traumatizing your clients. That's not what trauma-informed care is about. It's all those other aspects of the pillars of trauma-informed care that we're not providing a safe space. We are not showing ourselves as safe. Trust, transparency, all of those pillars. If we don't have any coping strategies, we can't bring us back down. And then we also can't regulate another dysregulated person when we are dysregulated. So if I'm screaming at a kid, telling them to relax, that's not gonna happen. And it's the same with our clients in the medical setting. I know one of my favorite things, I worked in acute care in grad school, and that was an first time working in that setting. One of my favorite types of people, I loved when people are coming, they're detoxing.
Yeah.
I can't think of the word for it, which, they might be one way one day and they come in, they're a different way and they act really inappropriately. One of my professors said it really interesting to me. I was working at a restaurant. I was a bartender throughout grad school, and she gave me some of the toughest, meanest clients. And I was like, what is wrong with you? Why are you doing this to me? Why are you giving me all these tough clients? And she's like, Rachel, your experience in the bar working with people who are saying inappropriate things to you, you know how to tell them to stop, or you don't get flustered by it in a way that some of these 21-year-old girls in this cohort have never had to tell an older man to stop that. And I understood that that was a skill that I could bring into the profession of saying, you know what, you're not going to talk to me like that. But it's also coming from a place they don't have control of it, right? So if I scream back at the guy that, oh my God, blah, blah, we're not going anywhere. We're not going to get anything done there. So I just go, you know what? I'll come back another time, or you're not going to get to see me today. You get to hang out with me for 30 minutes, but I guess I'll go to someone else. And they're like, no, no, no. We are trying to build that relationship, but that dysregulation piece is so important to understand what triggers you and not taking things personally. I mean, we're working in highly stressful jobs where people's family members, their lives are on the line. And there's personal attacks against us. We have to be able to bring ourselves back to an equilibrium and say, they're stressed. It's okay. I don't need to react.
Yeah, and it's funny that you mentioned professors, because I had one who told me I was too, if I was showing empathy towards a patient, I was getting too personal, or if I shared that I, was also maybe not having the best day, and I, again, mentioning thank you for noticing, and I'm sorry that I'm off today. I'll try to get past it, or whatever I said. I think patients appreciate that, because how many times have you gone in, whether you were in whatever setting, school setting, VA, acute care, and you went in and they called you the speech nurse or the speech doctor or the doctor lady or whatever it is. It's hard for them to understand their role. And when you are in that sort of that hierarchy of authority, when you go into the room and they don't understand your role, and you go in and you acknowledge, yeah, today I'm not having the best day ever, it kind of makes you more human, because we sort of have this superhero mentality from a lot of our patients, particularly a lot of our older patients or our patients who have intellectual disabilities. There's a power differential that can be off-putting for a lot of people.
Oh, yeah.
And you want the patient to know and be aware that you know what you're doing, but you don't want it to be so lofty that you're unapproachable and you're not human and that they can't trust you. So it all goes back to that same situation of the guiding principles, because it makes you more accessible. It makes you more real. It's the collaboration piece and understanding that you could have a shared experience of also having a bad day, or just, like you said, traffic is trash and it really
Right.
makes you in a bad mood.
Right. And that collaboration piece, that's so important. I'm glad you brought that up because in the parenting strategy world, there's different types of parenting, right? There's authoritarian, authoritative, permissive, and neglectful. And I think a lot of people think that especially in the medical setting, that I'm authoritarian. I'm
Hmm.
the boss and you are the child. You have to listen to me. I know better than everyone. I think of myself as authoritative. And that's that shoulder to shoulder. Even if I'm working with a child, I'm saying, nope, we're on the same team. I'm not, don't you do that. I'm working alongside them, whatever their goals are. And in the medical setting, this is also able to be done. Yes, you do have the background knowledge and you can talk about, well, I learned about this or in my experience, but we are still on the same level we're on the same team. That was something that I always said to the people that I'm working with. We're on the same team here. We are, what are your ideas for therapy? What would you like to work on? That collaboration piece, instead of saying, we are working on this together. It's
Hmm.
not leaving any word for not leaving any room for collaboration. And that little change is so important to relationship building. That's the big piece. It helps build your relationship, which helps meet your goals that you are trying to meet.
Yeah. Well, and I think that kind of leads me into the next question, because there's a lot of research that's been done in the past few years. Dr. Yvette Heider has done some really great research, and there's a couple of other people that have. Carol Westby's done a lot of things with trauma informed care, but thinking about how trauma impacts language and communication is another thing that I wanted to talk about, because from a developmental standpoint, with you working in schools, you see that in a different way than how I've seen it. So can you kind of speak to the impact of trauma on the development of language and communication?
Yeah. So Yvette Heider and Carol Westby are my mentors in this field. The research that they've done is so incredible. And when I've
Yeah.
talked to both of them, I'm doing research with Dr. Westby right now. But when I've talked to both of them, we kind of see it that they are doing the research of the language development, and I'm like the after effect. I'm the what happens post trauma with adolescents still, but what happens post trauma. What we have seen with children, it actually affects the brain development early on in age. And one of the groundbreaking studies was the ACE study done by Kaiser Permanente in the 1990s, which I try to get away from the ACE study just because what the ACE study originally did was it only had 10 things on a list of possible traumatic events. How many things are we leaving off that list? But the conclusion of that research article was that the more traumatic events in childhood, the worse physical health outcomes in adulthood, up to a 20-year decrease in life expectancy, cancer, diabetes, all of these physical health outcomes. So we know that traumatic events as a child affects that our bodies in such a way that it affects our lifespan as adults. From a development standpoint and a speech pathologist, what I typically see is diagnosis of, oh, that's a learning disability, that's a this. And we have a lot of students who are diagnosed with a learning disability. We can't say, oh, well, that's because of trauma. But if we have this substantive background of what they've been through, it makes sense why they've been diagnosed with a language disability or learning disability. One thing I always like to say is I'm a person who's been diagnosed with PTSD and ADHD. The symptoms of both of those are almost exactly the same. So if I'm losing my train of thought, I can't be like, oh, well, this one was because of the PTSD and the other one today was because of the ADHD. We can't separate the symptoms like that. So in the school system, we see that a student's not paying attention and they get evaluated, they get the psychoeducational evaluation. And based on the symptoms, they are given, well, ADHD because they can't concentrate, or it's OHI, other health impairment. So they
Mhm.
find that all of these symptoms cause the student executive functioning concerns. They're distracted, they're not sleeping, they're all this. And they get the help, the support they need from that OHI diagnosis or eligibility. But we as SLPs, we like to say, I know that kid, that's an ADHD kid immediately. And I want us to try to get away from that pathology like thinking and just saying, what symptom is this? How can I support them with this? And not just saying, oh, that's a behavior thing, that's the ADHD thing, that's the trauma thing. We don't need to associate it like that. We don't need to blame a specific behavior on, well, that's the trauma, that's the this. We are there to help support our clients with whatever symptoms are showing up within our scope. And it could be from trauma, it could be from high stress environments, it could be from a lot of things, which school also causes trauma, also could be a high stress environment, and not just home life. A lot of SLPs I hear all the time, they'll say, we're safe here. Like this school is safe from whatever happens at home. And it's like, there's also trauma existing in the school, bullying, educational impact. There's so many things that I can talk about trauma, but the short story is that trauma does affect brain development and can contribute to what we are seeing early on in life, early on in therapy. They are coming to us because their brain development was due to traumatic events, and that is why they are seeing a speech pathologist.
Yeah, no, I 100% agree. And another diagnosis that pops up that I present on a lot is concussions and post-concussion syndromes shares, again, those ADHD criterion. It shares criterion with PTSD as well. And so, again, all of those things, those can be intertwined as well. We know that clients who have concussions and post-concussion syndrome can have these mental health issues and these pre-existing ADHD components that then all sort of look like one big ball of wax, but it's really not. And it's really hard to tease out what came first, the chicken or the egg, if you will.
Right, right.
But the point is, what is our treatment going to look like? Because I think some people are still very focused on the diagnosis is this, so we need to be looking at this, but they're not looking at the diagnosis is this, but what are we seeing in the room with the client or in this space where they're interacting with other people, whether it's kids, whether it's their family, whether it's other adults across settings.
Absolutely. And a quick story that made me think of is after what I experienced at my school, we had a bunch of staff resign. We got new staff the next year. One of the new staff members was an ROTC teacher at a high school. So this is a person who has been in the military for a long time, and they are training children to prepare for military world. And we have a staff meeting planning week before all the students come back to help prepare us for the new year. And we're all in the library. We're talking to a psychologist who's telling us how we reacclimate students in the new year. And this ROTC teacher just raises his hand and he goes, now, can I get a list of the students who have PTSD, or how do I know which students have PTSD? And I was enraged. And I didn't know why. And it took me a day to think about, and then I tried to find him the next day. I went up to him and I was like, you have to treat every single person on this campus as though they've experienced trauma. But I understand from a military standpoint, working with military, nothing can be done until there's a diagnosis.
Yeah.
There's no support available until there's a diagnosis. So I wanted to say, like, you're so on the right track. And I did tell him, you're on the right track, but you know what has happened here. Assume everyone has been affected by it. And that would be easier for you than adjusting your language for this kid and adjusting what you do for that kid. Just do it for everyone. You know what everyone has experienced. And I saw a light bulb go off in his head that, oh, that is an easier way, or that's a more trauma-informed way to go about it, trying to prevent harm to as many people as possible.
Yeah, and that goes back to those, I don't know if we touched on the universal precautions, but thinking about some kids or even adults have had not only one crisis, but they've had multiple. And it's kind of funny because I know you're in Florida and you all have had some seriously crazy storms this year across your state. And I was talking to my husband earlier because when we were at ASHA, and I don't know if you know this, there was a earthquake in California.
I did, because I got the notification and I went like this and I go, I'm not doing this today.
Yeah, but it was not funny, haha, but funny, like weird, because I was reflecting back that we were stationed in Iceland years ago, and we had an earthquake while we were there, and then when I came back home, when I was working in IPR, I was at work, and my son was, gosh, he was early teens, so he had just gotten home from school, and we had an earthquake here that was very atypical. We don't, Virginia, we don't really, if we do, we don't know about it, but we had an earthquake. But we've had, being on the coast, we have tropical storms and nor'easters and all these things, hurricanes. We had a volcano erupt when I was living in Iceland. So, and you don't, again, we think of trauma sometimes, I think, as this physical manifestation or this violent event that was a physical assault or
Yes.
maybe even emotional or verbal assaults. And we don't think about natural disasters a lot. But a lot of our kids and a lot of our 20 something patients who are exhibiting sort of more high risk behaviors that place them at a higher risk for substance abuse or TBI, motor vehicle crashes, those kinds of things. And not that they're not always exhibiting high risk behaviors, but there's statistics that show that. But they've had these things too that were impactful. Think about Hurricane Katrina and how many people got displaced from their home as a kid who are now, much older, and it's still affecting them. They were houseless.
Yep.
They were displaced from their families. Some of them had parents or grandparents who passed away or siblings. That's a lot.
It is.
Think
And
about natural disasters.
absolutely. And natural disasters are one of the potentially traumatic events. So we've moved away from ACEs, things that are
Mhm.
potentially traumatic. And that is one of them, especially in Florida. I give the self 5 all day, every day. One of the passages is about hurricane season. And I don't want to give that test in Florida because we deal with hurricane season every year. I don't know what their history is, especially this one where it was so unexpected to the people in North Carolina that what you just talked about is actually a complex trauma with Hurricane Katrina because it
Yeah.
was the one event that created housing issues, food scarcity, job. It contributes to more factors. So we have a lot of our students and the people that come into the medical setting that are there due to some of those issues. And I just was thinking about the hospital that I worked at. One thing that really bothered me, there was a large homeless community that we were in a downtown area, which this is very typical of city areas. There's a large homeless population. And I remember here medical professionals talking very flippantly about that population. Oh, they get hit by a car so they can come have a nice place to stay. And I just think of how untrauma informed, non-trauma informed that is, how many complex traumas. I want to know the history of that person, what got them to that point. And I want to know about the people who are working in the medical setting that are now thinking with that mindset that it's not person centered at all. It's not empathetic at all. It's not understanding the systems behind what got that person to put their body at risk to do that. So there's little things that I think there's that compassion fatigue, there is the stress. And for people, especially in the medical setting, to get by, they have to compartmentalize. And medical providers have some of the darkest humor, the darkest
Yeah.
humor. And part of that is because they've lost their filter. They see some of the
Yeah.
worst things and their senses have been dulled to that. So when I hear people say certain things, I don't automatically yell at them. I'm not like, how dare you say that? My question is, what happened to you? And that leads me to, if you are interested in learning about trauma informed care, one of my favorite resources to recommend is the book What Happened to You by Oprah and Dr. Bruce Perry,
Mhm.
especially the audiobook. I think it is a great introduction into trauma informed care rather than some of the other highly recommended books on it that are just so intense or so medical that it's like, let me get a little grasp on it. And if I want more, then I'll go into those books like The Body Keeps a Score, The Deepest Well. There's so many books about the effects of trauma. What happened to you is changing that phrasing from what's wrong with you to what happened to you. So if
Mhm.
someone is acting not in the way that I think is an appropriate response, I'm always asking myself, how did they get there? Why are they
Mhm.
saying that? And that can be used with your coworkers, that can be used with your family, that can be used with your patients, their family. There's so many levels that trauma-informed care can be on, but anytime someone says something that I'm like, "That was an interesting thought," I always ask myself, "How did they get there? What happened to
Mhm.
you?"
Yeah, and I think that takes the no judgment piece as a universal precaution into play because again, when you think about people who have worked in certain settings, they do so, and sometimes it's a defense mechanism because it's painful to go home and think about these things that you know your patients have been through or bad things that have happened in your community that resulted in maybe a mass casualty or something like that where it's easy on the outside looking in, but you have to look at it from what if this was your loved one? What if this
Mhm.
was your friend? Having that judgment piece taken out of it, because that way you can start to provide a more healing and safe environment. But one of the other things I kind of wanted to touch on was, and this isn't part of our learner objectives, it's just more of a something that I like to talk about too, is the self care for us as practitioners, because I think our jobs are very stressful. Our pay is very low for the level of education that we have. And it is really hard, like, self-care, what does that mean? Go
Yes.
listen to some music or, I think a lot of people have a hard time because we're always looking at helping others, but not necessarily taking care of ourselves.
And
So
I was gonna say, I think I hear it from grad students all the time that in their
yes.
classes they hear, "Go do self-care," and they're like, "When? I don't have the time for it." And us in our jobs, right? It's a little like it's a slap on the wrist that it's like, "Go do self-care, make sure you're doing that," but then they make you do 100% productivity and you're stressed out of your mind. It works both ways. What I say really is the self-care is holding boundaries, work-life boundaries, that's a big one. If you have families at home, that's really hard for you to be like, "Go take a bubble bath, go watch Wicked, go do whatever." Like, we can't just take the time to do those things. I'm very lucky that I don't have other people that I have to take care of, and I can sleep all day if I want to. I'm someone who knows that I need a bit more sleep than other people, so I won't feel bad about, "Oh, sorry, I can't come to this that early tomorrow," or "Let's do lunch a little bit later. I need to sleep in tomorrow." I don't need to tell them the reason why. I'm just, "No, let's get together tomorrow, but how about this time instead?" You have to advocate for yourself also. In the school system, I'm always encouraging SLPs to advocate. In Florida, we don't have a caseload cap. So my first year as a CF, I had 120 kids on my caseload and thought that was normal. And then I go to ASHA and I hear that Washington State has a caseload cap of 45 or 55 and I'm like, that doesn't sound real. What do you mean? So we need to advocate for ourselves also in the medical setting. We need to talk about that productivity standard. I like to use that more in self care because those are really the things that make or break our jobs. When I see the difference in someone's enjoyment of their job, or at least not so stressed, it's the boundaries at work. And you can take the time to do whatever you need to outside of work within your own schedule. But I think that's a bit harder to control because we have a lot of things we have to do outside of work. But self care is a tough subject because it's just used of make sure you do self care, and it's like, but you guys are the ones causing harm to me in my job. You do self-care. And in the school system, it's a joke. Here's a pencil. Here's your self-care. There's a pizza party for you guys. That's our
Pizza,
self-care.
yeah.
Yeah.
Pizza
Always.
is us too, and it's usually like one slice, and
Yeah.
we don't also have time to eat that because they've already watched you to see how many times you peed that day. So
Exactly.
there's
Right.
that
Right.
part.
Exactly. So I think a lot of people laugh when they're being told, make sure you do self-care. And it's like, all right, I'll go do that. Thank you. It's really about self-advocacy, holding boundaries, especially in toxic work environments that are burning you out. You have to hold those boundaries.
And I think that's scary for people because they think, and I've been there, I've done that, being afraid that you'll lose your job when you do establish a boundary because especially if you're in a toxic environment. But when you do that and you give yourself that permission to advocate for yourself and you realize, okay, you know what? I love this job so much, but maybe this isn't the right place for me. And you find somewhere else that's a better fit, which is scary and hard. And I totally get that. Again, this time last year, I was exactly in that space. And yeah, I'm like a different person now
Right.
because
And I hear
I don't
some
work there
people,
anymore.
right. And some people work in rural areas that it's not possible to just switch jobs like that. And
Mhm.
that is much harder.
Yeah.
If you are in a position that you do have multiple job opportunities around, whether it's in your SLP field, or if you can go bartend, if you could do whatever, I have to tell you, working at a Pilates studio, I see how enjoyable it is. People walk
Mhm.
in and they say, I look beautiful that day, and I'm like, why are you acting so weird? Like I'm used to a toxic work environment, and I'm seeing how other people do it, and I'm like, oh, people are able to enjoy work. The instructors are so happy. The GM is so happy. We can still advocate for that within our jobs, but I do understand when people are not able to just make a switch with financial insecurity or whatever the factor is, but start keeping an eye out of, maybe I can make this switch. Maybe I can look into other jobs. You can always go interview. I always say go on as many interviews as you want. See what else is out there, because you're not going to know. You might have your dream job that you interview for and put you in a better position, but you have to look into those jobs.
Yeah, no, and I agree 100%. Anything else that you feel like you want to leave us with or you want to talk about? We have a couple minutes.
I saw that someone wrote in the Q&A, and I'd be happy to answer that. They said, I've been hearing terms like neurodiversity and theories of neurological system needs rather than pathologizing people. Makes me wonder, is a major shift needed to consider maybe it's a minority of the public that doesn't have some level of post-trauma stress? We know the statistics are that trauma is extremely pervasive. By age 16, we think that 60% of children have experienced at least one potentially traumatic experience. So if you're working with a 96-year-old, they've experienced 16 several times over, right? The likelihood that they've experienced multiple traumas, generational traumas, is very high. I do think that there's a significant movement towards not pathologizing. However, in the medical system, the DSM-5 rules all. We have to, follow these codes and everything. In the medical setting, I don't think it's going to change so much, especially because insurance is involved. But from our personal mindsets as the providers, it absolutely can be a part of you evaluating someone. In the educational setting, I mean, we're talking more about neurodiversity affirming care, which in my view, I made this post on Instagram of the umbrella of do no harm. I see
Yeah.
trauma informed as the umbrella and neurodiversity affirming care as like a part of it, because the goal of neurodiversity affirming care is to not cause harm to neurodiverse individuals. So I think there is a real movement towards acknowledging that. The medical setting is very difficult because it's so bound by codes,
Yeah.
corporation. It's very hard. But I agree. I think that we are moving in that direction, and I think we should be moving in that direction.
Yeah, and I think we're also trying in academia to move in that direction as well by restructuring some of the things because I know my graduate program and I was a full-grown adult. I was married and had a house and children when I went back to graduate school, and it was still incredibly traumatizing to juggle and do all the things. And yeah, I can't imagine if I was 22-year-old or 23-year-old me and trying to do that. So I think there's some things in place that are it again, everything moves slowly. It's like trying to walk through water sometimes, when you're in water and you have if you've ever gone snorkeling and you've got those shoes on that prevent you from cutting up your feet and you're trying to
Hmm.
just walk into where you can get deep enough to look underneath the water. It's like really slow moving. And I feel like that's how we are when moving in these fields of looking at trauma informed care and also the neurodiversity affirming. I think it, like you said, I think that's pretty pivotal for us and trying to work that into our practice for people who aren't doing it already. But Rachel, I just want to say thank you so much. It took us a little while to connect, and I'm so glad we did because I think this was really great.
It was
Um, and I appreciate the work that you're doing behind the scenes and in front of the scenes but a lot, I know a lot of it is behind the scenes and doing it on your off time and your own time. So I just really appreciate that. And hopefully I get to work with you again in the future. So
I'd
again,
love
thank
to. Thank you
Yeah.
for having me. I'm happy to finally see you see you on the screen, but we were in the same vicinity in Seattle. Just
Yeah,
never met.
I know. But we got 2025 coming up, so it's all
We
good.
do. We do. Thank you, everyone.
Yeah, thank you for being here. Thanks again, Rachel, and we look forward to seeing you again,
Thank you for having me.
of course.
If you have indicated that you are part of the ASHA registry and entered both your ASHA number and a complete address in your account profile prior to the course completion, we will submit earned CEUs to ASHA. Please allow 1 to 2 months from the completion date for your CEUs to be reflected on your ASHA transcript. Each episode comes with an accompanying course on speechtherapypd.com, available for a 0.1 ASHA CEU. And just for our listeners, get $20 off any subscription with promo code BRAINSTORMS20. SpeechTherapyPD.com is run by SLPs for SLPs. We've got the largest library of ASHA CEU eligible courses out there, adding fresh content every week. Remember, use BRAINSTORMS20 to get $20 off access to over 1,000 courses for an entire year. Head over to SpeechTherapyPD.com for more information and start earning CEs today. Thanks for tuning in to Brainstorms, Functional Neuro Rehab for SLPs. And don't forget, SpeechTherapyPD.com is your go-to for all things ASHA CEUs. Your positive reviews and support mean the world to us. We'd love for you to drop us a quick review and hit that follow button.